Stephen Boucher from the University of Calgary. Dr. Boucher is the former clinical medical director at the Operational Stress Injury Clinic at Calgary, Alberta in Canada. He is a clinical assistant professor in the University of Calgary's Cummings School of Medicine, Department of Psychiatry. He received the Queen's Jubilee Medal for services to veterans in 2013. On the subject, we're all in this together, the Interdisciplinary OSI treatment team. Please welcome Dr. Stephen Boucher.
Thanks to Karen, thanks to the Road Home organization and the Australian Centre for Excellence. What's impressed me over the last couple of days is the progressive conversations in Australia and the research, and how stigma, the wall of stigma is falling in Australia, and wonderful to see that. But time pushes, so I'm going to move on. And I was asked to talk about my experiences for the last 13 years in our operational stress injury clinics in Calgary, treating currently serving members, military veterans, our federal police force, the Royal Canadian Mounted Police members, and RCMP veterans. For those of you who don't know what an OSI is, an operational stress injury in Canada was introduced by Veteran Affairs Canada to reflect persistent psychological difficulties that occur as a result of operational duties while serving in Canadian forces. It's a non-medical term. So why do we have the treatment services that we have in Canada? And I think there's a few reasons for that. We have them because of our history, because of our geography. Like Australia, we're a huge country. We have a single-payer healthcare system. There's no private practice. And finally, the nature of the injury. So we're going to start by looking back at history. So it's 1917. Canadian forces have been involved in World War I, and we have 15,000 mental health casualties. And the plan at the time was to treat patients in the UK with rest and recovery, return them to the front. That didn't happen for many soldiers, and they were returned to Canada to our inpatient military hospitals in Ontario and Montreal. And then come 1918, there was no vision in our mental health profession to see PTSD, shell shock, as a chronic condition. Our patients were sadly discharged to the community, and between the wars, we closed our military hospitals, downsized them, and any care for military veterans was done in the community system. In the 1990s, that was no longer going to work. Canada, our forces were heavily involved with UN Blue Beret missions throughout the world, Rwanda, Somalia, Bosnia, and the government began to recognize we had an increased number of military veterans with PTSD, with trauma conditions. We get to the 2000s, we're now recognizing the damaging effects of military sexual trauma. We become involved in the war in terror in Afghanistan, and there are attempts to destigmatize mental health issues in our military. So we have a problem in Canada in the early 2000s. Some of you may have met retired Lieutenant Colonel Stéphane Grenier, who became a special advisor to the government on mental health issues in our veterans and military. And he pointed out to the government that our public system is overwhelmed, our public system is ill-equipped to cope with the unique mental health needs of our military. How big is the problem in Canada? Well, I was surprised to find out the number of veterans we have in Canada. So the 2016 Life After Service survey reveals 670,000 military veterans living in Canada. 23% have been diagnosed with one or more mental health disorders. In the year prior to the study, 5.8% were experiencing suicidal ideation, and 1.1% had attempted suicide. So it is a big problem in our country. In the early 2000s, though, the people of Canada got behind our veterans and first responders, and our government got behind our veterans, and it's become a national priority for the country to provide services to our veterans. Quick map of Canada, big country, very like Australia. We have quite a few cities, a lot of rural populations. In 2002, we had one small inpatient unit in Montreal. We had a small veterans mental health clinic in Montreal. There was nothing else throughout the country. So our federal government, through VA, began to sign letters of understanding with our provincial mental health authorities. We would not engage in building of inpatient units, military inpatient units. They opted to develop a network of operational stress injury outpatient clinics across the country. I'm from Alberta, so way to the west. We have two clinics in our province, one in Edmonton, about 3 hours north of us. I'm in the Calgary clinic. We now have 11 operational stress injury clinics across the country. We are now developing satellite clinics to meet more rural services. There's now about 10 satellite clinics. We have one just established about an hour and a half north of Calgary. We're working on one about 3 hours south of Calgary. Since the beginning of the network, we have treated 20,000 military veterans as outpatients in this network, and that is quite an achievement. We began in Calgary in 2006 with a manager, 2 psychologists, and myself, a few pencils, and we were told to apply evidence-based treatments. In our first year, we had 95 referrals. Since then, we have done 4 renovations. We now have about 450 active files. We get about 220 referrals a year. We have about 30 staff to now support our satellite clinics. What we've learned over the years is how complex the injuries are, or how complex operational stress injuries are. We've grown in size to reflect that complexity, and this is what happens. When we assess our patients, these are complex injuries. 80% of our patients have 2 or more mental health disorders. 50+% have 3 or more mental health disorders. So you need a team with expertise in understanding complex mental health conditions. We talked yesterday about the synergy between childhood adverse experiences for some of our patients and repetitive cumulative trauma in the military or in the police service. It's very important to make the diagnosis, not miss the diagnosis. I time and time again see patients treated elsewhere. The expertise hasn't been there and the patient has been misdiagnosed. The other aspect of complexity is this aspect. You have to have depth in the team to understand the injury and develop relationships in the community. I particularly like Sarah McClay's group study of Australian Vietnam vets, which looks at PTSD and the medical comorbidities. And she and her team ask for PTSD to be conceptualized not as a mental disorder purely, but as a systemic disorder. So within our clinic, we are dealing not just with mental illness, but also profound physical and functional impairment and an overlap with physical illness. We see more cardiac disease, we see more autoimmune disease, irritable bowel. We have to develop relationships with specialists and family physicians. Chronic pain is a big issue. More than 50% of our patients are suffering with chronic pain. We have a pain specialist, a pain physician come into our clinic, and we deliver a pain group, an educational group, We're very conscious of excess use of opiates. We're struggling to make sense of medicinal marijuana in Calgary. We're fortunate we have access to acute pain treatment services and federally funded chronic pain treatment in the community. Addictions is a big issue. During PTSD, about up to 75% of patients can experience issues with addictions at some time. Having an addiction is not a complete barrier to treatment. We have access to federally funded residential treatment if needed, but many patients come into the clinic, contain the addiction, and smoothly move through treatment. Finally, sleep. This is a huge issue. I've always used assessment of when did your sleep change in my interviewing of patients to look for the inflection point when the patient's gone from healthy to on that slippery slope down. We recognize the very high incidence of complex sleep disorders in this population. Some studies, up to 50% of patients will have obstructive sleep apnea. We have very good relationships with specialist sleep physicians in Calgary, and level 1 sleep studies are the gold standard. If you miss the diagnosis of an obstructive sleep apnea, your outcomes are not going to be good. Your patients are going to remain chronically impaired. It's really important to assess sleep issues as well in police with shift work, etc. It's absolutely key that your team understands those issues. So, we're all in this together. That was the title for my talk. And we are an interdisciplinary team. So we have brought together some of the best trained health practitioners available in mental health. The complexity of the injury needs an interdisciplinary team. We come from diverse mental health fields. We sometimes use different language. We have to learn to communicate with each other and communicate with our patients. We all work in the same office: psychiatrists, nurse clinicians, occupational therapists, social workers, psychologists. We share a common goal, a common vision. Cross-training and shared responsibilities are the norm. No one works in a silo in our clinic. Every patient has an individual therapist, and as much as we can, a psychiatrist as well. Meetings between the therapist, the client, their partner, the psychiatrist are encouraged. We strive to be interdisciplinary and we do not work alone. We have regular treatment meetings where we sit down as a team and consult with each other on our patients' care and outcomes. We also strive to take care of each other. We have a weekly, what we call success team meeting, and that can be a process group. This work is emotionally taxing. It is also an exciting group sometimes where we review new research and we look to the future. Our patients come into our clinic at a high level of distress. We recognize the importance of the operational stress injury support workers, a federally funded peer who themselves suffers with an OSI. They are very helpful in breaking down stigma and the barrier to treatment. We recognize the importance support we get from the Royal Canadian Legion service officers who also help break down those barriers. By the end of the clinical intake, patients will know that their treatment has a beginning, a middle, and an end. Our treatment's divided into 4 stages. Weekly treatment for about 60 to 90 minutes. For the first 6, maybe 12 months, I think we're doing better than this. This is from probably 2009. I think we're doing better. We're delivering treatment more quickly. How many inpatients, how many patients do we admit to an inpatient unit? Probably about 4 a year from our clinic out of our 450 files. So we use inpatients for short-term treatment, short-term stabilization, and then come back and complete the treatment in the team. We're fortunate that our psychiatrist, one of our psychiatrists works in inpatients, so they get the same guy, the same treatment. Stabilization, a really important phase of treatment. We have a wait list like most everywhere. We can deliver stabilization in a group format, so our patients come to the clinic or through telehealth if they live far away. We have 9 psychoed topics we go through. We teach grounding, diaphragm breathing. We're teaching skills right from the get-go before they start with the individual therapist. We do pre and post. This makes a difference. I was skeptical that it would, but it makes a difference in beginning to reduce symptoms. Individual therapy is where the patient forms that therapeutic relationship of trust. During this phase, we do more psychoeducation. We develop a developmental genogram for those of you who were at the talk yesterday on accelerated resolution therapy. We complete a trauma timeline, and we move quickly into exposure-based treatment. During this phase, we may do something with medication, we may attend to addictions, etc. But we're recognizing the Ad de Jong group. If you've never read Dr. Ad de Jong's 2016 paper, and FOA and others, we're moving to far shorter stabilization, much earlier intervention with exposure treatment, especially accelerated resolution therapy. It's been a paradigm shift in our clinic, and our patients are asking for the accelerated resolution therapy. However, we may need to involve one of our psychiatrists. Sometimes we'll start medications at the get-go, but we don't have a strong focus on medications. We actually use very little medications. About a third of our patients absolutely need medications to stabilize. We don't get into complex medications. If we need a medication, it'll be an anti-anxiety, antidepressant, possible use of an atypical neuroleptic at low dose for the shortest time possible. I have never cured anybody with a medication in an OSI clinic. I've saved lives by treating suicidality, but I've never cured anyone. I spend more time taking patients off medication than adding medications. ADHD, previously remitted ADHD, can relapse in war zone exposure, so you have to be attentive to diagnosing that and watch the right hand here, and treating that. Exposure treatment is the single most important thing you will do for a patient. We started out with CBT, we moved to prolonged exposure, cognitive processing, EMDR. All of our therapists get trained in multiple exposure treatments. We recognize the benefits of exposure treatment and the shortcomings of the evidence-based accepted exposure treatments like CPT, PE, and EMDR. The failure rates are high with those treatments, and we have a management style of encouragement to risk-taking and evolution in our clinic. We learned about accelerated resolution therapy about 2014-15. We have adopted that in the clinic. With ART, we're able to treat sicker patients more quickly with better outcomes. Our patients talk to each other and say, I don't want PE, I don't want CPT, I want accelerated resolution therapy. We talked about some of the emerging research there. There is going to be more solid research coming in the next year. However, no treatment is totally effective for these complex injuries, but I'm pleased to report a new innovation in our clinic. We're always looking to the future. We're very fortunate. We're well supported by charities in Calgary. In January, the Calgary Health Trust, I guess they installed for us, they gave us an RTMS machine. My colleague, Dr. Hurst, tells me this is the future of medicine. It's been very interesting. We put about 24, 25 patients through this treatment. And who are we asking to do this treatment? These are our treatment-resistant patients. They have failed multiple medication trials. They have failed multiple trials of exposure treatment. For many of them, the exposure treatment has led to the PTSD symptoms have gone away. They're in remission from PTSD, but they are still functionally impaired by depression and anxiety. So we have had 24 patients. I've got the results on 13 patients. This isn't research. We're at the sort of pre and post. Very intriguing findings. 78% of patients have had a 10-point drop in the PCL-5, so a clinically measurable, worthwhile drop in the scores for PTSD. 71% of our patients become subclinical on the PCL-5 after a course of RTMS. We also do the PHQ-9, the OQ-45 anxiety scales. 66% of our patients are having a 50% drop in the PHQ-9 scores, so a very significant drop in depression. We're using technical details, left dorsolateral prefrontal, because of the amount of comorbid depression. Patients come in, they get treatment daily for 4 weeks to 6 weeks. We've had patients living 3 hours away. They come and stay in Calgary for the week, go home over a weekend, and they will do that for 4 to 6 weeks. I have had patients profoundly treatment resistant, chronically suicidal, done every treatment we can think of, and I think this is going to be a game changer for our clinic. There are patients that I have been able to discharge in remission. Quite remarkable. We're excited about this. We're getting ethics approval to do some research with this. Last slide. So we believe in post-traumatic growth. Most of our police officers are working while they're in treatment, and we certainly see them as very resilient individuals, great assets to the police service. They can go back and talk to other members to encourage them to come for treatment. We have a wellness recovery action plan group that helps patients prior to discharge to look at the triggers they're going to face in their life and to use the tools that they've learned in the clinic to move forward in their lives. We send aggregate data to Montreal for the government to assess, are we making a difference? But in the clinic, we were introducing new exposure therapies. We wanted to try and sort of measure what we're doing. We do pre and post studies before exposure treatment, after exposure treatment, using PCL-5, PHQ for depression, the GAD for anxiety, and an OQ-45. And we are seeing significant reductions in anxiety, depression, overall distress after treatment in our clinic. And our patients are 5.91 times less likely to report clinically significant PTSD symptoms at the end of treatment compared to the beginning. We set lofty goals in our clinic. We aim for remission, recovery, repair, return to full function. Yes, PTSD is a chronic condition, but we do set high goals and we aim to meet with them. We never give up, we never give in. And we always provide hope because there's no medication like hope. Thank you.
Thank you, Stephen, for bringing us up to speed on We're All in This Together, the OSI Interdisciplinary Treatment Team, and the progress that's being made in that area.